to get iodine 123. In our part of the world, it's mainly iodine 131. Thallium chloride for cancer and some thyroid nodules. Gallium citrate for lymphomas, anaplastic CA, thyroiditis, and abscesses. And technetium-99m, pentavalent DMSA or iodine 131 MIBG for medullary thyroid cancer. And these are the tracers that are available for medullary or neuroendocrine tumors, and there's a whole variety of them. Technetium-99m, pentavalent DMSA, technetium diprotide, indium octreotide, somatostatin receptor imaging agents, iodine 131, MIBG, sestamib. These are gamma camera based. And then if you look at the PET based tracers, you have fluorine 18 glucose or F18FDG, fluorodopa, and gallium, more recently, gallium 68, DOTA-TOC or DOTA-TATE scanning. So I'll go very briefly through thyroid, parathyroid, which I think we're getting less and less referrals. Adrenal cortex and medulla, hardly do nowadays. And then I'll mention a bit about neuroendocrine tumors. Now with the advent of FNAC or FNAB, I think we're getting very few referrals for thyroid scanning. And the two situations are really a small group of patients, as you have heard Professor Hussain this morning. They have low TSH, and you want to distinguish between thyroiditis and toxic nodular disease, whether it's single nodule or multinodular goiter. And you also have sometimes patients with Graves' disease who have a coincidental nodule. The second situation is where, again, less than 15%, and it's getting even less, where the fine needle aspiration biopsy reports a follicular neoplasm. And you want to then try and see if there's a hot nodule or a cold nodule, which we are more worried about. And this is an example of a hot nodule on the technetium-99m scan, and similarly also on a iodine 131 scan. Another patient with a right thyroid nodule, the technetium-99m pertechnetate scan shows a cold nodule, but when we use sestamib, it turns out that this is a hot nodule. Another patient, technetium-99m scan, hot nodule, iodine 131 scan, cold nodule, and sestamib, what we would call a warm nodule. It has been our experience, and we've published this about 15 or 16 years ago, that it's the warm nodules on the sestamib which are more likely to be malignant. So whenever you get a discrepancy between technetate and iodine, it would be quite useful to do a sestamib thyroid scan. These are some other examples of thyroid scanning, thyromegaly, toxic goiters, and anatomical delineation. Again, hot nodule, normal, cold nodule, and the lingual thyroid, which we sometimes miss. In terms of function, euthyroid, thyrotoxicosis, you can also get a high uptake with iodine deficiency goiter. And of course, you hardly get any tracer uptake in the thyroid, hypothyroidism, or with subacute thyroiditis. Now here's a patient with a cold nodule on the technetium-99m scan. No uptake also in the iodine 131 scan, but however on the thallium scan there is nodule as well as lymph node metastases. Another patient, non-Hodgkin's lymphoma, normal uptake in the thallium scan, and uptake only in the nodule on the gallium scan. These are fairly old slides, I must say. And of course, the whole body iodine 131 scan, which you've also seen earlier, patient with residual disease and very avid iodine 131 uptake in the lung metastases. Now, parathyroid imaging also, we are actually not seeing that many referrals. It is not the scan of first choice, and it's probably indicated more for prior to the second operation for primary hyperparathyroidism. And we can do this two ways. In the old days, we used thallium and technetium-99m subtraction techniques, and of course, some centers still do that. But we have gone the way of technetium-99m sestamib dual phase scan, early phase and a late phase. Now, the subtraction technique was used because one tracer goes to the thyroid and the other tracer is taken up by both thyroid and parathyroid. And so the argument, when you subtract, you're left with a parathyroid image. In the case of early and late scanning with sestamib, the washout from the thyroid is quite fast. So if you do a delayed image at 2 hours, whatever activity is left behind is what you're seeing in the parathyroid gland. Now, the average parathyroid weighs a very small amount, 40 milligrams or so, and it's difficult to do subtraction techniques. But when the parathyroid adenomas are hyper-functioning, they're close to 500 milligrams, and this can be used for these subtraction techniques. Here's one example, technetium-99m scan, iodine 131 scan, and the subtraction leaves you with a large parathyroid adenoma. Again, this is sestamib, delayed, early and late. So a very large parathyroid adenoma at 5 minutes, thyroid and parathyroid. At 1 hour, mainly the parathyroid. At 2 hours, and even at 4.5 hours, what you're seeing is the residual uptake in the parathyroid gland. Similarly, thyroid 5-minute scan with sestamib and 120-minute scan, there's still no washout in that very small parathyroid adenoma. And again, another dual phase, 20 minutes, 2 hours, and at 3.5 hours, there's still this focus of parathyroid uptake, which can guide the surgeon for treatment. Going on now to medullary thyroid cancer, I think the important point here is that it's associated with multiple endocrine neoplasia, and one should always be worried when the serum calcitonin level is elevated and the patient has diarrhea. The tracer which is ideal for medullary cancer thyroid is technetium-99m DMSA. It's cheap and we can make it ourselves in our own laboratories. But there are other tracers such as thallium, sestamib, iodine 131 or I123 MIBG. Again, these are expensive. And of course, you have the indium-labeled octreotide or somatostatin receptor agents. Again, good sensitivity, but very expensive. So here's a patient with thallium scanning in medullary cancer of the thyroid, tumor as well as nodal disease. DMSA scan in medullary thyroid cancer with multiple metastases. As I mentioned, for the adrenal, the old days we used to have the iodine no cholesterol, which has a high uptake for the adrenal cortex. And I think what's more relevant now is iodine 131 MIBG or meta-iodobenzyl guanidine, which has a high affinity for catecholamines, secreting tissues. So we can look at pheochromocytoma, neuroblastoma, and similarly related neoplasms. But just for historical, there's an adrenal tumor, which is adrenal carcinoma causing Cushing syndromes, and another one with a tumor here, but also showing uptake at that site. And a third one, again large tumor here, but uptake there. As I said, we are not doing these things as a routine. And I'll go now to neuroendocrine tumors. We know that they are originating from endocrine cells, and they have secretory granules, synthesize biological amines and peptides, and also have amine precursor uptake and decarboxylation, so sometimes called epidomas. And the thing is, we are able to image these tumors because they express peptide receptors in high quantities. We can either use our conventional nuclear medicine gamma camera techniques of SPECT and SPECT-CT, and the initial gold standard was indium-111 octreotide, but one can also use iodine or MIBG or DMSA5. But what's become interesting is that we are now able to use PET and PET-CT. And these tracers, like fluorine-18 fluorodeoxyglucose, looks at the metabolic response. Fluorine-18 DOPA or carbon-11 DOPA are actually amine precursors. Carbon-11 hydroxyephedrine and metomidate are looking at enzyme inhibition. And more recently, we have gallium-68, DOTATOC, DOTATATE, DOTANOC, which are actually somatostatin analogs. And this gives you an idea of molecular response. We won't go into detail about somatostatin receptors, but the thing is, only SSR2, SSR5, and SSRT3 have got good affinity for the commercial synthetic analogs. As I mentioned, indium-111 used to be the octreotide, used to be the gold standard, has a good affinity for SSRTR2, but gallium-68 with DOTATOC or DOTATATE has a higher affinity than indium octreotide. And more recently, gallium-68 DOTANOC has a good affinity for 2, 3, and 5 receptors. When we do PET scans, we also do what is called standardized uptake value, or SUVs, which you may see in the PET reports. And this is again much higher, almost 2 to 10 times higher for gallium-68 DOTANOC as compared to fluorine-18 FDG in those receptor-positive tumors. Now, neuroendocrine tumors, we may sometimes fail to visualize them on the conventional anatomic imaging, either the tumor or the metastases, or some specific tumors like gastroenteropancreatic tumors, bronchial carcinoids, medullary thyroid cancer, pheo, and paragangliomas. And this is an old scan from indium-111 pentriotide, and again shows you multiple sites of involvement in the lung, liver as well. And a patient with a carcinoid, again indium-111 octreotide, massive involvement of the liver and bones as well. Fluorodopa in a patient with a neuroendocrine tumor. You can see that there are a number of sites. And fluorodopa again in a glomus tumor. Indium 111 octreotide. So if you compare something which we can label technetium with, and you get the result within 4 hours, 1 hour, 4 hours, whereas with octreotide, you probably have to do another scan at 24 hours. But you can see the abnormality with technetium already. Another patient with a pancreatic tumor, we're using gallium dotatate. Small cell lung cancer, which is another type of neuroendocrine tumor. If we use our conventional metabolic agent, which is fluorodeoxyglucose, you can see the two foci of nodes, but the pictures are actually much clearer with fluorodopa. Here's a thyroid cancer patient, iodine 131 scan negative, FDG PET negative, but the serum thyroglobulin is still very high. So this is the whole body, anterior, posterior iodine scan. But the CT scan shows a lot of metastases in the lung. Oops. And the gallium 68 dotatate PET scan shows, in fact, multiple foci of tumor in the lungs, similar to your CT scan. So negative on iodine, but positive on gallium 68 for neuroendocrine tumors. So the FDG is useful in fast-growing, poorly differentiated tumors, but the somatostatin receptor scintigraphy with either gallium or MIBG is superior for well-differentiated tumors and carcinomas. Again, CT and PET-CT, you can see that there's a tumor in the pancreas as well as involvement of the spleen. And the bone lesion you can see quite nicely here, but also positive on the gallium 68. Again, thyroid cancer patient, there is expression of somatostatin receptors. Patients who have positive studies can then be treated with peptide receptor therapy, either lutetium dotatate or yttrium-90 dotatate for treatment. This is one patient with multiple sites of neuroendocrine tumor in the liver, pre-treatment. The neuroendocrine tumors are very responsive to radiation treatment. So this was yttrium-90 microspheres. And this is the angiogram showing multiple vascular blushes from tumor. And this is the post-treatment CT scan with after yttrium-90 microspheres. So very good response. And usually the larger tumors are treated with yttrium and the smaller tumors are treated with lutetium. So to assess the treatment response, we can use gallium-68, which is actually noted earlier than the metabolic response, which will come with FDG, or even earlier than the morphological response with CT, ultrasound, or MRI. And this is another patient with treatment, lutetium-177 from Germany. MIBG, yes, okay. And these are some of the indications for MIBG. And there's a positive uptake in a pheochromocytoma, positive uptake in the tumor as well as in the thyroid, extensive tumors on MIBG scanning, extensive neuroblastoma on iodine 131 MIBG scanning. Now this is a patient I want to go through with you. Pre-op, a sestam-EB scan showing medullary thyroid cancer and lymph nodes. Post-op, there's still residual disease. And this is with the DMSA pentavalent. You can see the uptake is much better than the sestam-EB. So the patient was sent to the surgeon, and whatever he has done, there's still residual disease after the thoracic surgery. And so we did diagnostic iodine-131 MIBG, and then therapy with iodine-131 MIBG, 300 millicuries. And this was a final study after we had to go to the OT and with the surgeon, cardiothoracic surgeon, take out whatever